Today, I'm going to be talking about PCOS, or Polycystic Ovarian Syndrome, from a primary care perspective. PCOS is the most commonly diagnosed endocrine disorder regarding ovarian dysfunction among women of reproductive age. It is also characterized by anovulation. A quick overview of the menstrual cycle. It is approximately 28 days long. During the first 14 days, the ovaries are gearing up to mature an egg to be released on day 14 during ovulation. And on day 14, this is when a woman is most fertile. The estrogen in a woman's body increases and it goes to the pituitary gland in the brain and tells the pituitary gland to secrete a hormone called luteinizing hormone around 12 to 24 hours before day 14. And that luteinizing hormone, it spikes incredibly and it goes to the ovaries and it tells that mature egg to be released from the follicle. And in PCOS, this does not occur. And this is for a couple of different reasons. One is that estrogen never spikes, and therefore luteinizing hormone never spikes. And it's that spike that releases the egg. Instead, in PCOS, there are constant high levels of luteinizing hormone and estrogen and very low levels of progesterone. Progesterone is a hormone that comes into play in the last 14 days of the female menstrual cycle, and that dip in progesterone is what causes a woman to have her period. But in PCOS, there is very little progesterone, and therefore there's no drop off and no period. So oftentimes, women with PCOS will come into the office complaining of very infrequent periods or no periods at all. The cause of this is unknown. It's thought to be tied to genetics and some epigenetics. Again, there are constant high levels of LH that prevent an LH surge, resulting in anovulation or no ovulation. This also means that they are infertile and they'll come into the office complaining, I've been trying to get pregnant and I can't. Anovulation results in cyst formation and low progesterone levels. So oftentimes, if we were to do an ultrasound on the ovaries, we would see many early and mid-stage immature follicles in the ovary. Another thing that happens in PCOS is that unopposed estrogen causes endometrial hyperplasia. So what does that mean? Estrogen is that construction manager that tells the uterus it needs to start building its lining, which is very healthy during the appropriate time. But if it continues to build and build and build that lining, there can be a risk for cancer, which is defined by overgrowth of cells. We need that progesterone to oppose that estrogen in order to prevent hyperplasia and cancer. Some signs and symptoms, and I've already discussed some of PCOS, are hirsutism, which is male pattern hair growth, and acne is another common symptom, and truncal obesity or fat growth, particularly on the abdomen. Additionally, acanthosis nigricans is another symptom, which is when there is a darkening of the skin on the neck. Seborrhea is another sign, which is dry, flaky, itchy skin. Alopecia, which is hair loss, usually in a male pattern. Depression, so a patient might come in saying they've been feeling depressed over the past couple months or years. They might present with a moon face or buffalo hump, which is similar to what is seen in Cushing's syndrome. So, how do we diagnose PCOS? PCOS is a diagnosis of exclusion, which means we need to rule out all other possibilities before we can diagnose with PCOS. So, first and foremost, because they will be often presenting with infrequent or no periods, we immediately need to perform a pregnancy test, which is usually done with HCG level urine test. If they're not pregnant, next we need to consider a possible thyroid disorder or hypothyroidism, and we'll measure this with TSH levels. The thyroid is fine. We want to see if there could be a possible tumor of the pituitary gland, which would cause prolactinemia, problem with prolactin levels, and we can draw prolactin. We also want to see if they have any glucose intolerance, and we'll do an oral glucose test. We want to draw a lipid profile and see if there's any dyslipidemia. And we also want to rule out other causes of hyperandrogenism, such as a problem with the adrenal gland. On ultrasound, you might see polycystic appearing ovaries, but this is not an absolute diagnosis and it has a very high false positive rate. In order to diagnose PCOS, you must see 2 out of 3 of the following: clinical or biochemical signs of hyperandrogenism, polycystic ovaries, and/or oligo or anovulation, infrequent or no ovulation. Labs we can draw in addition to assess for hyperandrogenism are increased androgens, such as DHEA. So for management of PCOS, for pharmacological management, you really need to ask the patient, are you trying to get pregnant? Are you not trying to get pregnant? If they are not desiring a pregnancy, combination oral contraception might be indicated, which is it contains estrogen and a non-androgenic form of progesterone. This kind of contraception also helps to alleviate the symptom of hirsutism, the hair growth. You could also give a progestin-only method, but this does not help to treat that symptom of hirsutism. If you were to give that progestin only, you could also additionally give an anti-androgen to target that hirsutism called spironolactone, but it cannot be given alone. Because it is teratogenic, which means it could be dangerous to a fetus, so it needs to be given in conjunction with some form of birth control. If they do want to get pregnant, then medroxyprogesterone acetate, sorry for that pronunciation, might be the way to go. It will help with some of the symptoms and also help them to have a regular period. They'll take it in the first 14 days of their cycle and then they will stop. Additionally, we need to give them some kind of insulin sensitizing agent such as metformin, and this will help to normalize insulin and sugar levels and help with pregnancy. So when we have diagnosed with PCOS, the patient is at risk for some other comorbidities that we need to assess for, such as metabolic syndrome, diabetes type 2, cardiovascular disease, hyperlipidemia, endometrial hyperplasia, and cancer. So for patient education, we really need to be encouraging early intervention to prevent and manage the aforementioned comorbidities. We also need to be educating and promoting lifestyle modifications, such as diet changes, to incorporate high fiber, protein, and to lower their sources of cholesterol and saturated fats. We want to encourage 30 minutes of structured exercise daily and some weight management if they do need to lose weight. However, not every PCOS patient needs to be losing weight, but probably should incorporate some diet changes. Following up with appointments and screenings for comorbidities, like mentioned before. And lastly, for follow-up, if they do have diabetes, dyslipidemia, and hypertension, we want to treat those accordingly. If they have not been diagnosed with diabetes, we want to screen for diabetes every year, and we want to repeat lipid profiles every 2 years. And if they have hypertension, teach smoking cessation. And remember, the most important thing is to determine which symptoms are most concerning for your patient before going forward with a treatment plan. Thank you so much.